Thank you very much for joining us today. Today, we are going to discuss a topic that every nephrologist, dialysis practitioner, nurse, and PD practitioner encounters sooner or later, but one that often creates uncertainty in daily practice: dry versus wet contamination in peritoneal dialysis. At first glance, these events may seem minor. Loose connection, dropped cap, or small dialysate leak can appear insignificant. But in reality, the way we interpret and respond to these situations can determine whether a patient simply resumes dialysis safely or develops one of the most serious complications of PD, which is peritonitis. Throughout this session, we'll focus on practical decision making. We will learn how to distinguish dry from wet contamination, understand why that distinction matters, review the current evidence and the international recommendations, and work through real clinical cases step by step. By the end of this presentations, you will have simple evidence-based framework to help you recognize contaminations events quickly, assess the true level of risk, and choose the most appropriate management strategy with confidence. So let's begin with understanding exactly what we mean by contamination in peritoneal dialysis and why not every contamination event carries the same level of risk. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator, so let's get started. Before we talk about management, we have to understand what wet contamination actually means. Because once you truly understand that concept, you will never confuse it with dry contamination again. Here is the easiest way to picture it. Imagine you are drinking water through a perfectly sterile straw. As long as nothing has passed through that straw, contamination is relatively contained. But the moment water is already flowing through it, and then the tip of straw touches a dirty table, that contamination now has a direct highway into the system. That's exactly what happens in wet contamination. The key idea that dialysate has already entered the PD system. The pathway is now wet, continuous, and connected. If sterility is broken at that point, microorganisms no longer have to cross an empty space. They can simply travel along the fluid pathway toward the patient. Think of dialysate as building a bridge. Before fluid is present, there is no bridge. After fluid is present, the bridge exists, and bacteria can potentially cross it. Let's look at a few real life examples. The first one, a PD connection accidentally opens after the catheter has already been primed with dialysate. At that moment, the sterile pathway is exposed directly to the environment. Second, imagine that sterile end of transfer set accidentally touches a bed sheet or the patient's clothing after it has become wet. Even though the contact lasts only a second, the fluid creates a potential route for microorganisms. Third, suppose the disconnect cap accidentally falls off after system has already been filled with dialysate. Again, the protective barrier is lost while a continuous fluid pathway already exists. And finally, any break in aseptic technique during connection or disconnection, once the fluid is already present in the system, should immediately raise your concern for wet contamination. So don't memorize the examples, instead ask yourself one simple question every time. Was there already fluid connection, the sterile pathway to the patient when sterility was broken? If the answer is yes, you are dealing with wet contamination, and that's clinically important because the risk of microorganisms reaching the peritoneal cavity is substantially higher than with dry contamination. That single question will help you classify almost every contamination event correctly. Now that we understand the definitions, the next question is probably the most important one. Why do we even care whether contamination is dry or wet? The answer is simple, because the risk of peritonitis is completely different. Think about it in this way. Imagine you are trying to walk across a field. If the ground is dry and broken, it's difficult to move from one side to the other. But if someone suddenly builds a smooth bridge connecting both sides, crossing becomes effortless. That's exactly what dialysate does. The moment fluid enters the PD system, it creates a continuous liquid bridge, and bacteria love liquid environments. They don't have to jump. They don't have to survive on a dry surface. They can simply move along that moist pathway toward the peritoneal cavity. So moisture isn't just water, it's about transport medium. That's why the distinction matters. With dry contamination, the sterile components are touched or exposed before they ever become wet with dialysate. Since there is no continuous fluid pathway, the chance of bacteria reaching the patient is much lower. In many cases, replacing the contamination cap or connector is all that's needed. Now compare that with wet contamination. Here, contamination happens after dialysate is already present. At that point, we have essentially connected the outside environments directly to the patient's peritoneal cavity through a fluid-filled pathway. That's why the risk increased dramatically. This is also why wet contamination usually requires a much more aggressive response, including prophylactic antibiotics and sometimes replacing the transfer set or even performing a system exchange depending on the situation and local policy and protocol. The take home message is this: don't focus on whether someone briefly touched the connector, focus on when they touched it. Was the system still dry, or had dialysate already created a fluid pathway? That single difference changed the biology, changed the risk of bacterial migration, and ultimately changes your management. So remember this one sentence: dry contamination is exposure without a pathway. Wet contamination, exposure with a pathway. And once there is pathway, bacteria have much easier journey through the peritoneal cavity, which is why wet contamination should always command much greater respect. Now let's talk about the management of wet contamination, and the first principle is simple. Don't panic, but don't ignore it. Think of this like accidentally touching the sterile tip of an IV catheter before inserting it. Even if nothing has happened yet, the sterility has already been compromised and broken. In peritoneal dialysis, once fluid has contaminated the open system before infusion, we must assume microorganisms may have entered. The first step is to stop immediately and recognize the contamination. Don't continue the exchange. Preventing contamination from reaching the peritoneal cavity is always better than treating peritonitis later. Next, replace the contaminated components. Any tubing, transverses, or dialysate bag that has been exposed should be exchanged immediately according to your center's protocol and policy. Never try to clean or reuse contaminated sterile equipments. After that, consider prophylactic antibiotics. Many PD programs recommend single oral dose of first-generation cephalosporins, such as cefalexin, provided there is no allergy and local protocol support its use. The goal is to eliminate bacteria before they have chance to establish an infection. Finally, monitor the patients closely over the following days. Advise the patient to report abdominal pain, cloudy effluent, fever, or any symptoms suggestive of peritonitis immediately. Early recognition allows prompt treatment and significantly improves the outcomes. The key message is that wet contamination is a preventable event. Few minutes of appropriate action today can prevent serious episodes of PD peritonitis tomorrow. Let's apply everything we have discussed to a real clinical scenario you have see in your clinic. Our patient is a 61-year-old man with diabetic kidney disease who has been successfully performing CEPD for the past 3 years. He's on standard regimen for 4 exchange per day, and importantly, he has never had any episode of peritonitis. So this is an experienced patient, not a beginner. Now, here what's happened during his evening exchange: he accidentally disconnects the transfer set before placing the sterile cap. As a result, about 5 to 10 millimeters of dialysate leak from the open transfer set. While it's still wet, the exposed transfer set brushes against his shirt sleeve. He reconnects everything and completes the exchange without thinking much about it. Several hours later, he realized what happened and called the PD unit. At this point, he is completely asymptomatic. He has no abdominal pain, no fever, no nausea, no vomiting, and his dialysate remains crystal clear. His vital signs are also reassuring, with a normal blood pressure, heart rate, and temperature. So here's the important question: would you simply reassure him because he feels well, or should you intervene even though there are no signs of peritonitis? This is exactly where understanding the concept of wet contamination becomes critical. The absence of symptoms does not exclude bacterial inoculation. Remember, peritonitis develops over time. Right now, we are in the window where prevention may still be possible. The goal is not to treat established infection, but to stop infection before it ever begins. So based on this scenario, what would your next step be? Now that we have seen the scenario, let's think like experts. Rather than jumping straight to the answer, let's break the case down into the key clinical questions that every nephrologist should ask. First, is this wet contamination or dry contamination? That distinction changed everything. Was there fluid present where contamination occurred? Because if the transfer set was still wet, with dialysate, bacteria can hatch right through that fluid directly to the system. Second, does this patient actually have PD peritonitis right now? He feels well, has no abdominal pain, no fever, and his effluent is crystal clear, so we are dealing with an established infection. Or are we simply trying to prevent one from developing? Third, should we send dialysate for cell count or culture? Would testing clear dialysate is in an asymptomatic patient provide useful information for us, or would it simply create confusion with little clinical value? Fourth, should we give prophylactic antibiotics? This is probably the most controversial and most important question. Is the contamination significant enough to justify antibiotics prophylaxis, or is careful observation alone sufficient? Fifth, should we replace the transfer set once the sterile pathway has been exposed and contaminated is cleaning enough, or should the contaminated component be exchanged or restore a sterile system? And finally, does this patient need hospital admission? Can be managed safely as an outpatient with education and close follow-up, or if there is any indication for inpatient observation? These six questions from a practical framework for approaching any contamination event in peritoneal dialysis. If you can answer them systematically, you will be able to manage almost every case with confidence. Let's answer our questions one by one and build the management plan step by step. First, this is clearly wet contamination. Why? Because dialysate had already leaked from transfer set, meaning the connection was wet when it touched a non-sterile surface. That thin film of fluid creates directly pathway for bacteria to travel and migrate towards the peritoneal cavity. Second, he does not have peritonitis, at least not yet. He has no abdominal pain, no fever, no cloudy effluent, and no evidence of inflammation. There is an important distinction. We are dealing with a contamination event, not an established infection. Our goal is prevention, not treatment. Third, there is no need to send dialysate for cell count or culture at this stage. The effluent is completely clear and the patient is asymptomatic. Sampling immediately after contamination is unlikely to provide a meaningful information and may lead to unnecessary concern. We reserve dialysate analysis for patients who develop symptoms, or cloudy effluent. So before we even discuss antibiotics or changing that transfer set, we have already established three key facts. This is wet contamination, there is no current peritonitis, and routine dialysate sampling is not indicated. At that point, those conclusions guide everything that comes next. Now that we have confirmed this is wet contamination without established peritonitis, the focus shifts to immediate management. The objective is simple: eliminate the contamination risk before it becomes an established infection. The first step is to stop using the contaminated connection once the sterile pathway has been compromised. Continuing to use that transfer set is no longer safe. Every additional manipulation increases the opportunity for bacteria to enter the peritoneal cavity. Next, replace the transfer set as soon as possible. This is a preferred strategy because it restores a sterile connection. If immediate replacement isn't available, clamp the catheter, keep the system closed, arrange an urgent transfer set exchange. The key principle is to minimize any further exposure. Third step is prophylactic antibiotics. Although the patient has no signs of peritonitis, wet contamination carries a meaningful risk of bacterial inoculation. Most PT programs recommend prophylaxis typically with oral cephalexin or fluxacillin, depending on local microbiology protocols and allergy status. Here we are treating the risk, not an established infection, as we mentioned. Finally, educate the patient before sending them home. They should understand that the danger isn't over just because they feel well today. They need to seek immediate medical attention if they notice cloudy dialysate, abdominal pain, fever, nausea, chills, before they may be the early signs that peritonitis is developing. So the management can be summarized in 4 actions. Stop the contaminated connections, replace that transfer set, administer prophylactic antibiotics, provide clear safety net instructions with close follow-ups. That's the approach that prevents contamination event from becoming a true peritonitis episode. Finally, let's discuss what happens after the patient leaves the PD unit, because successful management doesn't end with the initial intervention. The first priority is close follow-up over the next 48 to 72 hours. During that period, we reassess the patient for any new symptoms, inspect the dialysate for cloudiness, reinforce proper exchange techniques, and determine whether additional retraining is needed to prevent future contamination. If the patient remains completely asymptomatic with clear effluent, routine cell counts or cultures are not recommended. A common question is why not simply observe from the beginning? The answer is that wet contamination is fundamentally different from dry. Once fluid is present, bacteria can already have gained access to fluid pathway before any symptoms appear. By the time abdominal pain, cloudy effluent develops, the opportunity for prevention has already been lost. That's why early prophylaxis is recommended in many PT programs. Another important question is whether intraperitoneal antibiotics should be given. In general, the answer is no. For any asymptomatic A patient with wet contamination most centers use oral prophylactic antibiotics. Intraperitoneal antibiotics are reserved for patients with suspected or confirmed peritonitis, not for contamination alone. And finally, does this patient need hospital admission or not? In most cases, also no. If the patient is hemodynamically stable, asymptomatic, reliable, and able to return immediately if symptoms develop, management can safely be completed as an outpatient with clear instruction and close follow-ups. So the key takeaway is this: wet contamination deserve prompt action, but not aggressive treatment. Replace the contaminated equipment, provide appropriate prophylaxis, educate the patient, and monitor closely. Acting early prevents a contamination event from becoming a peritonitis episode at the end. And finally, let's conclude the key message I hope you will remember long after this presentation. The first and perhaps most important point is that exposure doesn't equal peritonitis. Wet contamination is an exposure event, not a diagnosis of infection. Peritonitis still requires compatible clinical finding, such as abdominal pain, cloudy effluent, supported by dialysate evidence. Our job is to intervene before infection becomes established. This is a clear message. The second message is that prophylactic antibiotics have an important prevention role because bacteria may already have entered the flow pathway during wet contamination. Many PD programs recommend early oral antibiotics prophylaxis with the exact regimen guided by local microbiology protocols and policy. The third principle is replace the contaminated transversate once sterility has been compromised. The safest approach is immediate change of the contaminated part component rather than continuing to use it. And finally, follow-up is just as important as the initial intervention. Most patients remain well, but symptoms can appear over the next 24 to 72 hours. Patient education, clear safety net advice, and close outpatient follow-up are essential if the patient remains asymptomatic with persistently clear effluent. Routine cultures are unnecessary. Let me finish with one example, if that is worth remembering, if it's not simply in a clinic. Dry contamination, generally lower risk event, may only require replacing the cap depending on local protocol. In contrast to wet contamination, carries substantially higher risk of peritonitis because microorganisms may already have entered the fluid pathway. That's why wet contamination usually warrants transversate replacement, at least, and prophylactic antibiotics. If you remember only one sentence from today's talk, let's be this: treat wet contamination early before it becomes peritonitis. Prevention is always easier than cure. Thank you so much for watching till the end. I hope I covered the topic in a simple way, and hope I will see you all in the next lecture. Thank you so much.